And we are going to kick off our afternoon sessions with a keynote presentation from Dr. Karen Herbst. Take it away, Karen.
Thank you. Do I only have 10 minutes? Okay. Keep going. Perfect. Okay. So there are many theories of what causes lipedema, and this is just one of them. So today I'm going to talk about compartment syndrome. And here's my disclosures. So before I proceed, I want to tell you about my colleague, Dr. Jose Luis Simaro. He is in Madrid, Spain, and he contacted me a number of years ago because I had written some things that were very similar to what he was thinking. And he said, would you like to work with me on this project? So he got his MD degree in 1979, and he became a family doctor. But he really wanted to do something else. So in 1998, he graduated in cosmetic medicine and surgery and anti-aging medicine and nutrition because he really wants to figure out how to reduce this abnormal fat using non-surgical techniques. And in 2007, he founded the Lipedema Institute, whose purpose is to achieve a better diagnosis of lipedema, to investigate its pathophysiology, and to develop non-surgical treatments. And he is one of the nicest, most humble doctors that I have ever met. Like if I say, I don't know if you should be doing that or you should be doing this, he goes, you know, you're right. And he actually listens to what you say and puts things into practice. So he's listening now, so I hope I do him justice. So we all know lipedema, but this is my first slide, and I'm going to repeat this at the end. So it affects primarily women. The adipose tissue is nodular. The limbs are primarily affected, although we know it can occur elsewhere on the body. The feet and hands are generally unaffected, and everyone wonders why. It's often painful or tender, it feels heavy, easy bruising is common, and there's edema in the tissue. And at least that's what I think, and I follow Shelley Krasinski's work because I think she's done the best job of showing that there's edema in the tissue. So we want to know why. So first, let's look at the difference between female fat and male fat. And I showed this last year, but I just love this comparison. So if you look at the male skin on the right, you can see that there's these little tiny fat lobules right under the skin on the top. So they have more fat under the skin than women do. But look at the tissue for the females. Do you see that the septums are really thin and transparent? You can almost see through them. And do you see how many more thick septal connections there are in the fat tissue for men? So could it be that there is a genetic or a hormonal influence on our fat tissue from conception that makes us different? And in fact, when they measured the strength of the fat connective tissue, men's fat was stronger. It makes perfect sense. So my question is, does weaker adipose connective tissue in women predispose them to developing lipedema? And is that why this happens more often in women than men? So do you see where the excess tissue on the upper arm is located? Is that, you sure you can see that? So here's the arm, and you can see that this is showing two compartments. So the compartment with the biceps and the compartment with the triceps in it. So that's kind of our first concept, that there are different compartments in the arm. It's not just muscle and fat and bone, and they're all scrunched on top of each other, and there's no separation between them. In fact, there is a separation between them. And this is the arm. Here's the triceps area. And you see right here, this little area, this is largely ignored in the literature. In many cartoons of the arm, you don't even see that area, and that's actually another compartment. And you see the yellow inside of there? That's fat. So if your fat can grow on the outside, can your fat grow on the inside as well? And maybe that can lead partially to this, and that's what we're going to talk about. So these are two pictures from Dr. Simaro, and you can see he's outlined the lipedema fat on the back of the arm, and that is right in this compartment area, and we think that this compartment is very important in that. So that's your first introduction to compartments. So what is a compartment? And I'm going to primarily focus on the leg because the leg is primarily affected in lipedema. So a compartment is a piece of connective tissue that surrounds muscles or nerves, blood vessels, lymphatic vessels, and adipose tissue. And it's present in your arms and legs, and you can see the compartment there. And the role of the fascia around these compartments is to keep the tissue in place. Otherwise, we would be like little candles and melting onto the floor, right? And so that fascia is pretty strong, and it does not expand very easily. So what is compartment syndrome? So if you've probably, I know some people read about it and they are reading about acute compartment syndrome. There's like nothing that I could find, and maybe there's, maybe one publication on subclinical compartment syndrome. But compartment syndrome is when there's increased pressure inside that compartment. And acutely, it can damage all the components inside, and it's really a medical emergency. And oftentimes, people who have a bleed into their leg will have compartment syndrome because that fluid builds up in the compartment and it builds up pressure and it starts killing off the muscle, which would not be good. But subclinical compartment syndrome is when pressure builds up within that compartment slowly over time, causing damage. And it could cause damage to that fascia, right? And if that fascia is already kind of weak because you're a woman, could it stretch a little bit? And then could fluid build up in there over time? And fat loves a fluidy environment. It will grow in a fluid environment full of nutrients. So could that be part of how lipedema starts? So it could either be fluid buildup, expansion of adipose tissue, or maybe even damaged fascia that would contribute to that compartment, subclinical compartment syndrome. And at least from my work, I know, and also, I know that Tom Wright knows this, that a lot of women with lipedema have hypermobile joints. So they have some sort of connective tissue issue that affects their fascia. And we found that it was close to 60%. We repeated that in a second study and found again that it was close to 60%. And working with Tom, it's about close to 60%. So at least here in the US, I feel comfortable we're at about 60%. And if you talk to Dr. Simaro, he says it's more like 80%. So could these changes in the joint connective tissue also affect the fascia and make it more pliable, more compliant? Fat you want to grow? Sure. But we also think inflammation is important in lipedema, and you heard about that today. You heard about mast cells, you heard about macrophages. And with Marisol Allen and Michael Schwartz, who's here today, we did a study where we biopsied women, and we looked at the blood vessels in the dermis of the skin. And we came up with a leaky vessel phenotype based on the lymphedema literature. What did the lymphedema literature show about what a leaky vessel is? And you can see there's two vessels here in the skin, or one vessel contorted. And around here you see white. That white is fluid. So there's fluid around the vessel. The the dark arrow here is pointing to an increased amount of immune cells that surround that vessel, and the two round cells here are rounded up endothelial cells that are associated with leakage. So that was our leaky vessel phenotype, and we published that in 2020. Then in 2022, a group out of Vienna said, leaky vessel phenotype, let's check that and make sure that that's real, which is great. That's what has to happen in science. Somebody else has to do what you did and prove that, yeah, that's actually there. So they did something really cool. They used artificial intelligence, and they asked the AI, what is a leaky vessel phenotype and what is a non-leaky vessel phenotype? And so here, this is a control, so non-lipedema, and see how nice and robust looking that vessel is? The AI said that's a normal endothelial cell growing in culture. And on the bottom, see that little weakling right there? That's a leaky vessel phenotype, and that's from a woman with lipedema. And sure enough, what AI found is that women with lipedema had more leaky vessels than women without lipedema. And then they said, how does that happen? So they took the lipedema fat and threw it in a culture and grew it up. And whatever the fat the fat cells and the immune cells in that culture gave off, they collected it, and then they put it back onto normal endothelial cells in culture. And what happened? Those endothelial cells began to leak. So there's something being secreted by the lipedema tissue that is causing this leaky vessel phenotype, and it likely has to do with inflammation. And I'm sure they're furiously looking to find that, whatever that is. So it'll be really exciting when that comes out. So you've got a lot of fluid coming out of your endothelial cells and entering the fat tissue. So here's your fat cells, and inside of fat tissue in that interstitial space are sugar molecules called glycosaminoglycans. And those glycosaminoglycans bind to a protein backbone, forming a proteoglycan. And they make these complex structures, and they bind up fluid, or fluid can exist free in the tissue. And tissue does not like to sit in fluid. It doesn't like it. It drowns. It becomes hypoxic, which you also heard about this morning. So what happens, your lymphatics have to pump that fluid out. And so if we're putting more fluid into lipedema tissue, are our lymphatics pumping it out at a much higher rate? So John Rasmussen and his colleagues looked at lymphatic vessels early in lipedema, and this is pumping rate. And you can see controls are down here, and look at women with stage 1 and 2 lipedema. And unfortunately, there are only 2 stage 3. But look at the pumping rates in lipedema compared to controls. So those lymphatics are going. They're going and going and going. Are they getting all the fluid out of the tissue? No. So what's happening, whatever fluid they're leaving behind is causing fat to grow. And also, look at the lymphatics were dilated, and sometimes the fluid was pooling in them. So even though they're working really hard, they probably are not working completely effectively. So how does lipedema begin then? So from what we've learned, we know that female hormones likely play a role just in the structure of our tissue. We know that maybe other genetics play a role, and maybe some of those genetics includes hypermobile joints or hypermobile tissue that affects the fascia. And then we know that inflammation is important. Well, where does that come from? Does it come from the macrophages in the tissue or the mast cells in the tissue? And vein disease, we also know that a lot of women with lipedema have vein issues. Is there inflammation coming from there? And also, gut issues. A lot of women have gut issues. Is the microbiome important? Is leaky gut important? So all of these things may contribute to inflammation, leaky vessels, stagnant fluid, and fat overgrowth. So what fat is overgrowing? So this is a cartoon of the skin, and then there's 2 layers of fat tissue here, a superficial subcutaneous adipose tissue, shown here as superficial SAT, or deep subcutaneous adipose tissue. And both of these are compartments because they're surrounded by fascia. So here's a superficial fascia, a deep fascia, and then the skin. These compartments are very different. The superficial adipose tissue preferentially produces the hormone adiponectin, which is an insulin-sensitizing hormone. And maybe that accounts for why women with lipedema can gain a lot of adipose tissue, but yet still not have diabetes. There's also bigger fat cells, or hypertrophy. There's less inflammation in that layer, and the vessel size is smaller. In the deep layer, that deep layer overexpresses inflammatory genes. That deep layer is kind of like visceral fat. So you've got your visceral fat and the abdominal fat on the outside. And that's the similarity to what you have going on in your leg. But actually, there are more than just 2 compartments of fat in the tissue, and I alluded to this earlier. There's actually 3. So you've got your superficial adipose tissue on the outside, your deep adipose tissue, and then you've got this saphenous adipose tissue, or saphenous SAT. And inside the saphenous compartment is a vein, a lymphatic vessel, and a nerve. So we think, and this is our hypothesis, that lipedema tissue can be present in any of these 3 compartments. So just to get a better look at that saphenous compartment, So here's your skin, and then here's your superficial fat, and then here's your superficial fascial layer right here, and then here's your deep fat, and then here's your deep fascia right above the muscle. But right here is another piece of fascia called the saphenous fascia. And so the saphenous compartment is made up of two different fascia pieces. And inside there is the vein, lymphatic, and a nerve. And veins can actually pierce this fascia, and lymphatics can pierce it as well. So this is what it looks like on your leg. It's a pretty big compartment. So it's pretty big in the thigh, and it's a little bit smaller on the calf. And this is the greater saphenous compartment, and there's also another one which I'll show you. But look at the nerves inside that compartment. So let's say you overgrew your fat in that compartment, it's going to press on the nerves, right? And that's going to make them tender. And if you also had some leaky vessels and some extra fluid in there, that's probably not going to feel very good. And I think a lot of women do notice that they have tenderness on the inside of their leg. And this is kind of what the vein looks like going up the leg here. And then there's another one in the back called the small saphenous vein. And these are the two veins that you would go to Dr. Wright for if you had venous insufficiency, and he would close those off for you if they needed to be closed off. And what does that do to lipedema? What does that do to that saphenous compartment? Nobody really knows. But Dr. Wright will figure it out. So now we're going to look at the legs of ladies with lipedema. And do you see that saphenous compartment on that leg right there? Or over here? Or over there? So I now can see it on many women with lipedema. And if you squeeze that compartment, it's tender. So you can actually see the saphenous compartment, but there's also fat around it. So that doesn't mean that the superficial and deep compartments are not involved as well, and we'll talk about those at the end. So here's the smaller superficial saphenous vein compartment on the back of the leg. So it begins around the outside ankle bone. How many of you have a fat pad who have lipedema on the outside of their ankle bone? Yeah. So I asked, I was working with Michael Schwartz, and I said, you know that little fat pad, it would be interesting to see that. And he said, well, one of my patients wants me to take theirs off. So he took it off, and it was really difficult. It was, full. It was like a little fascia compartment in and of itself. That was probably the extension of this small saphenous compartment on the back of the leg. And he said he will never do it again. It was too hard to get out. But could it be that compartment syndrome, so increased fat within this small saphenous vein compartment and extra leaky fluid coming down here around the ankle are making that fat pad grow? And could that be a marker of compartment syndrome in the small saphenous vein compartment of the leg? Could it be? Do we have another sign for lipedema? And also within that compartment, in addition to fat, the saphenous vein, you have nerves, and then you have two types of fascia. So again, looking at the small saphenous vein that we just looked at here, okay, we're looking at this vein now, but we're cutting the leg like this. And you can see pink muscle, and you can see the saphenous compartment here. So here you are at rest, lying in bed, you get up, and you stand, and then you start to walk. And you can see that saphenous compartment that's normally, fairly visible on the leg, scrunches down. So when you contract your calf muscle, you're squeezing the saphenous compartment, both the greater saphenous compartment on the inside of the leg and the small saphenous compartment on the back side of the leg, so that fascia compartment flattens out, and whatever fluid's in there is moving up towards the heart. And that includes venous fluid and lymphatic fluid. So now you see how important contraction of those muscles are, How important is walking and moving and exercise? It's one of the most important things you can do to move your fluid out of the leg. So now we're going to look at the lipedema leg. So now we're looking at the greater saphenous vein here on the side. So here you have a non-contracted muscle, and you see the compartment here, and now you contract the muscle, and the compartment size doesn't change because there's too much fat inside. It can't squish down. Or there's something wrong with the fascia, so it no longer has that tension. So it never squishes down, so you're not moving your venous fluid or your lymphatic fluid as well anymore. So that fluid is now sitting in your leg. So let's revisit subclinical compartment syndrome. Increased pressure within any compartment of the leg. Happens slowly over time. It can compromise function within the compartment. It can compromise muscles in their compartment, and I'll show you why. That means they don't get good force generation, they can atrophy, and they can become fibrotic. And I know that in talking to Jamie Schwartz, he says when he does liposuction on the calf, he frees up the muscle, and women say for the first time they were able to generate force with their calf muscle. It can reduce lymphatic flow, so the lymph isn't flowing up. It reduces the flow of vein upwards. It causes nerve pain, and it can also cause capillary dilation and leakage. So maybe that's also contributing to leakage from blood vessels. So this is a very complicated diagram, and I'm sorry. And Dr. Cimaro has really worked on this diagram to make it even better. But here's your calf muscle pump, and here's a deep vein, and here's your saphenous vein on the side. Now, if the calf muscle contracts, it squeezes this compartment and blood moves up the superficial saphenous vein here. But it also moves from the superficial vein into the deep vein as well to move up. And that's through what's called a direct perforator vein. And it can also, when it contracts, move blood into a indirect perforator vein, which goes right into the muscle here. And this calf muscle is super vascular. So when it squeezes all that blood out of the muscle. And that goes directly into the deep vein and then up to your heart. Okay, so let's say you have subclinical compartment syndrome. You've grown a ton of fat in here. You try and squeeze your calf muscle. It doesn't work. What happens to that fluid? It goes and it sits in the muscle. And it might go over to the deep vein and move upward, but a lot of it's going to sit right here in the muscle. And then what? What happens when you get a lot of fluid in the tissue? You get some hypoxia. When you get hypoxia, you get inflammation. When you get inflammation, you get fibrosis, and now your muscle's in a cage. And now you try and contract that muscle, it doesn't work anymore, and it just starts compounding the problem. So now we have a compartment syndrome here in the greater saphenous vein compartment, and we have a compartment syndrome here in the muscle. So you've got a muscle compartment syndrome. And if you are a woman with lipedema, oftentimes when you try and squeeze the calf, you can't see any muscle. You can't feel any muscle. You don't see any definition, right? And that's where most of the lipedema tissue is often early on. You see younger people who have those tubular-shaped legs, right? And they go, look, when I was 6 or 7 or 9 or 12, I had cankles, or my legs look like tubes, right? And then the lipedema progresses over time. So if here's your greater saphenous vein compartment here, and it's got these indirect perforators that are going right into the muscle. So if this fluid stagnates right near the greater saphenous vein, and you press on that, is it going to feel good, or is it going to be painful? It's going to be painful. So this is a great spot to just compress in women with lipedema and see if they're tender, see if those muscles are tender, and oftentimes they are. And I believe Dr. Cimaro has validated this by ultrasound. So the lymphatics, this is the really cool part, so bear with this diagram. So do you see the light blue on the diagram? Those are superficial lymphatic vessels. So here's your skin, and you've got this complex lymphatic system within the skin, and here's a superficial lymphatic vessel. It's connected here to this superficial lymphatic vessel, and it's connected here to this vessel, so it pierces through that fascia, and now this superficial lymphatic vessel is in the saphenous fascia. It's dependent, so all the flow from up here is dependent on this vessel within the saphenous fascia to get squeezed and move all that fluid up the leg, right? If you're not squeezing this, all this fluid is sitting here in the tissue. Now, if you remember, let's go back real quick. Oops. If you remember here, do you see how the superficial venous system is connected to that deep venous system? There's a lot of connections between the superficial veins and the deep veins, lots of perforators that connect them together. There's no connection between the superficial lymphatic system and the deep lymphatic system in your leg. So you're out of luck if you cannot squeeze that saphenous compartment. If your calf muscle pump is not working and that fascia compartment is not stretching and becoming small and pushing that fluid up. So let's look at the lymphatic vessels in slightly a different way. So there's many lymphatic vessels in your leg that move up, and then there's a deep lymphatic system. And you can see there's no connections between the superficial lymphatic system in yellow or that deep lymphatic system, except every once in a while there's this little canal called Hunter's Canal, and you can have some connection there. The only place that the two systems are connected is in the foot. So if you have compartment syndrome and you're not pumping lymph up the leg, it's pushing fluid into the tissue of the leg, causing fat to grow. But in the foot, that deep venous system can still pump the fluid out. So it's pumping fluid out of your foot, but it's not pumping the fluid out of the rest of the tissue. And that's why we think the foot is not affected in lipedema. Does that make, I see nods, does that make sense? You got a place that fluid can move out in the deep system, but not the superficial system, and that superficial system is failing because of compartment syndrome within the saphenous compartment. So here's proof, and there's only a little bit of proof. This is a theory, okay, but there's a little bit of proof that this is true. So back in 2001, 22 years ago, Cagliati published a piece of lipedema tissue that he got from a woman with lipedema who had died. Bless her heart. And you can see here, the skin's on top. Here's the superficial and the deep fat on the top. And look at this. This is the saphenous, small saphenous vein compartment. Look how big that is. That's huge. And it's packed with fat tissue. And look how tiny the vein is. That vein is getting kind of compressed. And here is an ultrasound, skin on top. Here's the saphenous vein, and here's the saphenous vein compartment. It is just bulging. And I'm hoping Emily Eicher starts doing some ultrasound of the saphenous compartments. It'd be great to see what she ends up doing with that. But I think this is the first case where we can see that fat does grow in the saphenous compartment, and compartment syndrome may exist. So how does lipedema begin? So we talked about all the things that could lead to inflammation, leaky blood vessels, stagnant fluid, fat overgrowth, and compartment syndrome. And this compartment syndrome can affect your superficial fat, your deep fat, or your saphenous fat. So if it affects your deep fat and your saphenous, or your deep fat and your superficial fat, and you have maybe a connective tissue disease that makes your tissue just accommodate anything that comes in, that fat can grow, and so you may have less pain, more tissue. But if you grow fat within that saphenous compartment, you're going to have more pain early on with less tissue. So women who are very small, who come in with severe pain, may have more fat in their saphenous compartment and less fat in their superficial or their deep fat compartments. But if you grow fat in all three, you're going to have more fat and a lot of pain. So there are two different kind of phenotypes that we talk about in the literature when it comes to lipedema. There's the Allen and Hines phenotype, which is the woman's leg who has a tiny ankle, but she's got all that lipedema fat on the top. And then we have this one, which is the Moncorp's type, which we'll talk about next. But it's kind of funny because look how different those two calves look. And what do we call both of them? Lipedema, right? We don't differentiate between those two. We just say, oh, you have lipedema, we move on. We're not separating them out. We're not asking, why do you have an ankle and why do you not? So let's talk about this Allen and Hines phenotype. So the ankle is relatively thin. The superficial, and this is our theory, okay? This is for us all to cogitate on and figure out, because I think what I'm asking you to do is help us figure out why those two are so different. So your superficial fat and your deep fat, they're hyperplastic, they're growing a lot early on, especially in the thighs, right? And so you go through puberty and you're all of a sudden you got a big butt, some hips, and some thighs, and you're like, whoa, how did that happen overnight? Over time, this lipedema tissue starts releasing something into the blood, and we know that that's true from that study out of Vienna, right? The fat is releasing something that's causing blood vessels to leak. So it starts releasing stuff that enter the venous and the lymphatic system. They reach that saphenous compartment. And you know how ladies say, well, I used to only have it on my thighs, but now it's growing down my leg, right here in the saphenous compartment, right? So you start developing this subclinical saphenous compartment syndrome. And then you really start getting a lot of pain in that lower leg, in the calf, due to that pressure, the inflammation, and the increase in adipocytes. Now here's the Moncorp's rusticanus type, or with the pantaloon-looking calves. So this starts right from the beginning. The minute girls hit puberty, their legs hurt. Or even before puberty, their legs really hurt, right? Lots and lots of leg pain. And there's so much pressure in the saphenous compartment, it goes right down the leg, so the whole leg hurts. And the legs get that tubular shape. So the ankle is affected early on, but not enough for anyone to really do anything about it. Or, they look at it and they go, well, you look okay, right? But they have a lot of pain with it. But we don't know what to do with that. There's our young girls, right? And due to an increase in pressure, that pressure starts building up the leg. Lipedema tissue starts building up on the entire leg over time. And because that pressure is highest in the calf, that's where most of the fluid is coming out. That's where a lot of the fat is growing. So this may be the stage 0 lipedema, that pain in the legs with a little bit of an ankle. And that early pain in girls suggests that this could be happening even before puberty. So it may not be just female hormones, or it may be female hormones affecting the fetus. But this inflammatory aspect of lipedema tissue in the saphenous compartment and that tubular shape of the legs could appear really early on, and that's what we need to figure out. That's what we need to know. That's how we need to prevent lipedema in young girls. So here's my first slide revisited. Lipedema affects primarily women. So there's female hormones that may induce an inherent weakness in connective tissue. And they probably do something more. And I just was fascinated by Sarah Al-Gadban's talk, and I want her to give it to me slowly. And I want to soak up every inch of it because I found it to be fascinating. There's nodular adipose tissue, so that inflammation causes those leaky arterial vessels and adipocyte overgrowth, causing subclinical compartment syndrome, backflow of fluid into the tissue, surrounds the lobules, and then you can feel them. The limbs are primarily affected. Why is that? Because they have compartments containing veins, lymphatics, and nerves, and also muscles. And those compartments are made of connective tissue, and connective tissue mutations may play a role. The feet are unaffected. Well, now you know maybe why. Because both the deep and superficial lymphatic vessels drain the feet, but communicate poorly in the rest of the leg. So this backup of fluid from compartment syndrome affects the legs and not the feet. It's often painful or tender. Well, there's pressure on the nerves and there's inflammatory cytokines, and the nerves are affected by them as well. It feels heavy. There's excess fluid, there's fat, and there's fibrosis in the tissue. Easy bruising is common. We've got weak vessels secondary to inflammation and compartment pressure, and maybe also connective tissue disease. And there's edema in the tissue, which I truly believe. And inflammation induces a subclinical compartment syndrome combined with leaky vessels. You've got to have fluid in the tissue. And again, I say again, Shelley Krasinski, I think, has showed this really well by MRI. So final concepts to consider. Subclinical muscle compartment syndrome can develop in women with lipedema, and that reduces the effectiveness of the calf pump. So where should we be spending our time? We should remove or change that lipedema tissue around that calf muscle pump. And you can do this by lipedema reduction surgery or deep tissue therapy, or both, or something else that one of you come up with as I step back and retire someday. And that fat pad on the outside of the ankle that everyone wonders about might reflect that small saphenous vein compartment syndrome. And that medial leg pain may reflect greater saphenous vein dysfunction. Now, fat is everywhere on the body, and it's connected by that interstitial space organ, right? We heard about that. We all got excited about that in the past. We're all connected by that interstitial space. Doesn't that mean that lipedema tissue can occur anywhere on the body? Can't that fluid that accumulates in the leg be pushed up on the abdomen? And we heard also that by Guy Eakin that the nerves were affected in the abdomen and not the leg, right? Why can't it be on the chest and the breast and the chin and the head? And there are publications that there is lipedema on the scalp. So I believe that interstitial space is super important in the pathophysiology of lipedema spreading. So I think reducing vessel leakage and tissue inflammation, which will include some of these treatments up here, lipedema reduction surgery, deep tissue therapy, but also treatment of the veins, may be important for improving lipedema, and I think we need more research in that area. And I'm going to finish early, so thank you.
We have questions.
I hope I did a good job, Peppy.
So, Dr. Earps, do you see an actual diagnostic test anywhere on the horizon?
Oh my goodness. Well, I think we need to establish, as Guy spoke today, establish clinical signs of lipedema versus obesity. And I think, today we are kind of seeing some things. I think when the shin is completely covered by fat, that's a sign of lipedema. The fat pad may also be a sign of compartment syndrome. That the medial growth on the leg might be a sign of lipedema. So I think if we get our physical exams down, that'll be fabulous. It'll be fun to watch what comes out of Vienna for, what is that secreted molecule or molecules that's causing that leakage. And I'm sure they're furiously working at it. Who wouldn't want to figure that out? And I hope other people are too. The race is on. So I think I do see a diagnostic test in the horizon. And I also think that some imaging modalities are going to be very helpful in the future, like ultrasound and also Shelley Krasinski's MRI. I've said her name so many times, but I think her work is fabulous.
Another question. Do you view exercise, compression, eating patterns, and massages as equally important in treating lipedema?
I do, because those all help reduce inflammation. I think anything that you can do to reduce inflammation is important, but I don't think it's like a recipe, like you should do these 4 things and you should do the exact 4 things and you should do I don't think it's that way. I think we're all different, and we have to figure out how we personalize anti-inflammatory treatments to the person. And that's one of the things that I do is I look for, why do you have inflammation? So you have lipedema, okay, that's what you have, but why do you have inflammation? Do you have vein issues? Do you have allergies, a lot of allergies? Do you have food intolerances? Do you have an autoimmune disease? Are genetics going to be important to you? I think that the field just has opened up, and I think everybody should be their own advocate, and you should be trying to figure out where your inflammation is coming from, because your healthcare providers may not know that that's important for lipedema. And I think and so you have to be your own advocate, and if your healthcare provider won't work with you, check. Go to the next one and build your team.
Absolutely. What does the research, if any, show regarding the use of diuretics and lipedema fluid overload?
There's no research on diuretics in lipedema and fluid overload, but what diuretics do is they pull fluid out of that interstitial space and leave behind those glycosaminoglycans, which form into a thick gel. And then they draw more fluid back, and your body's like, oh gee, I better make some more glycosaminoglycans to bind up that water. And then you pull that water out, and those get smushed into a gel, and it kind of just builds up this big gel over time, which once it's there, it's a lot harder to get rid of. And that happens in both lymphedema and lipedema.
Absolutely. What is your experience with finding lipedema in men?
I have found lipedema in men, and often it's in men who have hypermobile joints. And the literature does report that it's often found in men who have low testosterone, so they're more estrogen dominant. So maybe they're growing a little bit of female fat, but for me, it's always been hypermobile men in a family that has hypermobility. So hypermobility is playing a big role in this, or connective tissue mutations are playing a big role, and therefore I think lipedema is a connective tissue disease.
How is compartment syndrome treated?
I have 10 treatments.
Here's your recipe.
So I think getting rid of as much of the tissue surrounding the compartments is important. I think reducing inflammation of the veins inside the compartment is important, and doing all the usual conservative therapies are important. I think that we need to figure out whether we're going to accept compartment syndrome as part of lipedema, and then use all of our brains to figure out how to treat it. But it is a tube, right? So pushing things up and out of the tube is important. So I think a lot of our current therapies are going to be useful, but we do have to figure out other things. And again, if you reduce the fat tissue around it, like by lipedema reduction surgery, it's going to allow a little bit more flexibility in that compartment.
Are there specific massage techniques that would help the saphenous vein compartments? Would calf raises and other lower leg exercises target those areas?
I think any kind of exercise is good, and using a muscle massager would be good, and using a roller would be good. And I think out of Vanderbilt, Paula Donahue has shown that suction works really good. So using a suction machine and pushing that fluid out of that compartment, I think would be very useful.
Does the pressure contribute to having major cramps in the legs, especially at night?
I think it does. But I also think that people with hypermobility who don't have lipedema can get a lot of cramping, because the fascia itself, when it becomes inflamed, contracts down, and over time it becomes stiff. So people with hypermobility can also get compartment syndrome in the absence of lipedema.
What is deep tissue therapy?
Deep tissue therapy is any movement into the tissue that's deeper than just surface manual lymphatic drainage. So this can include myofascial therapy, Swedish massage, Rolfing, muscle massagers, instrument-assisted soft tissue therapy, suction, anything that gets all the way down to the bone. And the most important thing is that you aren't taking your fascia blaster that you just bought and immediately going down to the bone with it, because that's going to cause damage in tissue that's also very sensitive. So I think it's important to think of it as layers, right? There's the superficial fat, the deep fat, and the saphenous fat. Go down in layers, slowly over time, but definitely work your way down to the bone.
Well, thank you, Dr. Earp, so much for your keynote presentation today and answering so many questions.